All right,
Yes, I can see that.
everyone can see them? Okay. Okay, so today I'm going to be talking about osteoporosis. First, we're going to go through the definition of osteoporosis and how to diagnose it. We'll then look at secondary evaluation and some labs that you can get when evaluating patients who have osteoporosis, and then talk about treatment and monitoring. So definition of osteoporosis, it's low bone mass or deterioration of bone tissue and disruption of bone architecture. This leads to compromised bone strength and puts patients at an increased risk for fracture. So as you can just see kind of the diagrams there of a normal bone and what osteoporotic bone may look like. According to the World Health Organization, we define osteoporosis according to T-scores, and we'll go through that in a second based on bone density scans. So a normal T-score is considered anything -1 or higher. Low bone mass or osteopenia is considered between -1 and -2.5, and a T-score of -2.5 or below defines osteoporosis. So why do we care so much about osteoporosis? According to the National Osteoporosis Foundation, it estimates that 10.2 million Americans have osteoporosis and that an additional 43 million have low bone mass. And more than 2 million osteoporosis-related fractures occur in the US, with 70% of those occurring in women. Hip fractures are the most serious consequence of osteoporosis, and women have an increased mortality of up to 20% during 2 years after they do have a hip fracture. And then something else to keep in mind is that more than 50% of survivors of hip fracture never return to independent living. So we really want to try and prevent these fractures before they occur. In order to diagnose osteoporosis, we use Dexa scan. So this is our gold standard way of diagnosing osteoporosis. You can see the patient lying on the scan. So they measure the bone mineral density at the hip and the spine. Those are the two common sites that we use. However, if for any reason we can't get a hip or a spine, sometimes patients have hip replacements or arthritis and other changes in the spine can give you falsely higher numbers in the spine, then you can also use a forearm as a third site. We also use the forearm if we're evaluating patients for primary hyperparathyroidism. DEXA scans are very safe for the patient and they provide very low radiation. So when you do get a bone density report, you'll see your T-scores and Z-scores. So the main thing for postmenopausal females is you want to look at their T-score. This is a comparison of a patient's bone mineral density with a young normal bone mineral density, and these differences are expressed as a standard deviation. Z-scores are also generally reported as well, and these are comparing a patient's bone mineral density with an age-matched bone mineral density, and these scores should be used in premenopausal women when you're evaluating for low bone density. So how do you actually diagnose it once you have the report in front of you? So it can be diagnosed in several ways, and this is according to the 2020 ACE guidelines for diagnosis of osteoporosis in postmenopausal females. So a T-score of -2.5 or below at the spine, the femoral neck, or the total proximal femur defines osteoporosis. And like I said, sometimes we do include that 1/3 radius. If you can't get another site, or if we're evaluating for hyperparathyroidism, then that 1/3 radius may be included. On most standard reports, it's not included, as usually just the spine and the hip. If a patient has a low trauma spine or hip fracture, so this could be just a fall from a standing position, irregardless of what their bone density is, that clinically defines osteoporosis. So if you have a patient that comes in with a low trauma spine or hip fracture, that already defines osteoporosis even before you know what their scores are on the bone density test, and they would qualify for treatment right away. If you have a T-score between -1 and -2.5, which is in that osteopenia range, and a fragility fracture of the humerus, pelvis, or distal forearm, again, this would define osteoporosis and they would meet criteria for treatment. And then the last one is a T-score between -1 and -2.5 and a high Fracs. The Fracs is a fracture risk assessment tool, which we're going to go through. So this is your Fracs score, which you can calculate this online. You can find this calculator online and just Google Fracs and this will come up. Basically, you enter a patient's different risk factors and it will come up with a Fracs score. The score that it gives is a 10-year probability of a hip fracture or 10-year probability of a major osteoporosis related fracture. An elevated Fracs score is considered greater than or equal to 3 for the hip fracture or greater than or equal to 20 for the osteoporotic related fracture. And so if you have a T-score in that osteopenia range, you need to calculate the score to figure out if they meet criteria for treatment. And if those numbers match the numbers that I had mentioned, then they would qualify as osteoporosis and would require treatment. So this is just, if you scroll down on the Fracs website, it just helps kind of define some of the features that you're going to be entering. So whether they're on steroids, what we consider secondary osteoporosis, alcohol use, etc. So this is just a helpful tool that you can read through when you're actually going through that calculator to make sure you're filling it in appropriately and according to, what risk factors they may have. A general tip about bone density scores or about Dexas. The most reliable way of comparing results from year to year or every couple years is a patient should have it done on the same bone density scan. So it's actually really important, if you can, to not send them to various bone density, to various locations to get their bone density. And if they can stick to one location and one machine, that's the most reliable way to compare from year to year, because there are small differences from machine to machine and from each technologist. So once you have the bone density scan and you've determined that the patient has osteoporosis, so we do consider doing additional lab workup. For all patients, you want to know what their creatinine and kidney function is, because that could guide your treatment. You want to know their calcium and vitamin D, because those are things you also need to optimize for bone health. Sometimes we do a more extensive treatment in patients who have had multiple fractures or they're on treatment and they continue to fracture despite being on treatment. Or they have very low T-scores, then we might do a kind of a more, what we say, secondary workup to look for other causes of low bone density. So other things we consider are checking their parathyroid hormone, checking their thyroid labs. We do a 24-hour urine collection to look for calcium. This can tell you a couple things. If it's low, they may not be getting enough calcium in their diet. If it's high, they may have something called idiopathic hypercalciuria, so they're just spilling out a bunch of calcium in their urine. And we can add on additional medications like a thiazide diuretic to help with this. Like I said, vitamin D and renal chem panel, and then other causes of low bone density include celiac, and you might want to check an SPEP or a UPEP, especially in patients who have lytic lesions. So moving on to treatment. So these are just the lifestyle changes that you want to discuss with all your patients for bone health. So weight-bearing exercise is important. So anything where gravity is working against your muscles. So things like walking, brisk walking, jogging are all considered weight-bearing exercises. Things like swimming are not necessarily weight-bearing, because really the water is, holding your muscles up, and so you're not really getting that the gravity working on those, so it's not as helpful for bone health. Balance improving exercises is important, especially in elderly patients who may be losing their balance and be more at risk for falls. Optimizing your calcium and vitamin D in all patients, even if you're not treating them with other medications, is important, and we'll go through that in a second. Minimizing falls, like I mentioned, especially in the elderly patients, you want to make sure to talk about risk factors of falls at home, loose carpets, rugs that might be around, cords and things like that, that you want to make sure they are aware of. Minimizing tobacco and alcohol use, and also minimizing caffeine. So in terms of calcium and vitamin D recommendations, women aged 51 years or older should consume 1,200 milligrams of calcium per day. This is a combination from all sources, so that includes diet and supplements. So what we typically recommend is to see how much they can get in their diet. We have charts and things online that you can find as well for how much different foods and how much calcium they have. And then whatever they're not able to get through the diet, you do want to go ahead and add a supplement if possible. And then you do want to make sure they're vitamin D replete. So the optimal level is controversial, but both ACE and the Endocrine Society recommend getting that vitamin D at least greater than or equal to 30. Okay, so now we're going to talk about some of the medications that you can use. So I'm going to focus on the ones that are typically used in the primary care setting. And then some of the kind of other agents that we use is a good referral point for endocrine. And so I'll just mention those as well. This is the ACE 2020 guidelines. It's just a good algorithm to use when you're thinking about which medication you want to use as your starting point. So basically, if you kind of go through the algorithm, it says, you know, first you diagnose it with the fragility factors or the low T scores or the high Fracs, as we discussed. And then you want to consider evaluating for causes of secondary osteoporosis. So those were some of those lab results that we had talked about, correcting their calcium and vitamin D, which we had mentioned. And then once you kind of get through the lifestyle, you're starting to think about which medication these patients may benefit from. So really you're dividing the patients into two categories. Are they high risk or are they very high risk? According to the ACE guidelines, very high risk patients are patients with very low T-scores. So generally we start thinking about T-scores of -3 or lower to be in that more very high risk category. Are they advanced age? Do they have other risk factors for falls? Are they on long-term steroids? Have they had multiple fractures in the past? So all of those would put your patients more in that very high risk category. So kind of moving initially to the high risk category, if they've had no prior fractures and they're not have any other factors that define them as very high risk, then still our bisphosphonates, which we'll go through, and denosumab are really kind of our first line treatments that we think about. If they're very high risk, then you actually want to start thinking about some of the other agents that we have, which are anabolic agents or bone building agents, things like abaloparatide or teriparatide, or a medication called Evenity. So those are some of the other sort of medications that you might want to think about if they're in that very high risk category. So just talking about bisphosphonates quickly, these are anti-resorptive agents that reduce the activity of bone-resorbing osteoclasts. And alendronate, risodronate, and zoledronic acid have evidence for broad-spectrum anti-fracture efficacy. However, abandronate is not recommended to reduce non-vertebral or hip fractures. So, you know, if you can, I think less commonly we use abandronate now just because it doesn't have that broad-spectrum efficacy. With oral bisphosphonates like Fosamax, we typically treat for about 5 years. With IV bisphosphonates like Reclast or zoledronic acid, we typically treat for about 3 years. And then after those 3 to 5 years of treatment, you want to consider a drug holiday. And we do that because patients who are on bisphosphonates for longer than that are at increased risk of some of the side effects, which we'll go through. However, patients who are very high risk may still need longer courses of the medication. But if you can get your patients off after 3 to 5 years and give them a drug holiday, that's important. And then you do have to be careful about their renal function. So they are contraindicated in patients with reduced GFR, so less than 30 to 35, depending on which medication you're choosing. Some of the side effects that you want to counsel your patients on, one of the main ones is GI side effects from the oral bisphosphonates. So patients can, especially patients who have reflux, they can have worsening reflux symptoms. So the main thing with oral bisphosphonates is that they should take it first thing in the morning with water on an empty stomach otherwise, and they shouldn't lay flat after taking it for about 45 minutes. So if they lay down, then that kind of increases the risk of having these GI problems. The two other risk factors that you want to talk about with bisphosphonates are atypical femur fractures and osteonecrosis of the jaw. So atypical femur fractures are insufficiency fractures in the femoral shaft. And these both atypical femur fractures and osteonecrosis of the jaw are pretty rare. but you should mention them to the patients. And that's why we want to think about that drug holiday after 3 to 5 years, because most of these problems occur when patients are on bisphosphonates for longer term. So if they're on bisphosphonates for greater than 5 years, then we start having, running into more issues with these. The IV bisphosphonate, so IV zoledronic acid or reclass, can cause an acute phase reaction. So after patients get that infusion, they might have fevers or muscle aches or pains for about 24 to 48 hours after they get that infusion. It's kind of like a flu-like illness. And so sometimes you can counsel patients to take Tylenol to reduce those symptoms. And then we kind of discussed the drug holiday already. So denosumab or Prolia is another medication that's commonly used in the primary care setting. It's the humanized monoclonal antibody, which reduces the differentiation of precursor cells into mature osteoclasts and decreases the function and survival of activated osteoclasts. It's given as a sub-Q injection, 60 milligrams every 6 months. So a couple things to remember with denosumab. A drug holiday is not recommended. So unlike bisphosphonates, which have a long half-life and stick around even after you stop the medication, denosumab kind of wears out of your system very quickly. And if you stop denosumab cold turkey, you're actually at increased risk of multiple vertebral fractures, and that can occur after stopping the medication. So for any reason you do need to stop Prolia, patients have to be transitioned to another anti-resorptive therapy. So they either need to be started on reclass or started on an oral bisphosphonate. Denosumab is okay to use in renal disease, but there is limited data in patients with CKD stage 5. And in all of the studies that we have, we know that denosumab treatment up to 10 years has a good safety profile. At this point, we don't have a lot of data beyond that 10 years. So side effects to watch out for with denosumab, one is a risk of hypocalcemia, so especially in patients with CKD. So if they do have a lower GFR, you want to keep an eye on their calcium and make sure they're not having any drop in their calcium after receiving Prolia. Sometimes patients have back pain after the injection. Again, it does have a risk of the osteonecrosis of the jaw and the atypical femur fracture, similar to bisphosphonates. Prolia can also increase your risk of certain infections like skin infections, UTIs, ear infections have been seen, and then sometimes an increased risk of derm reaction, so worsening of eczema or dermatitis. And then we'll briefly discuss raloxifene as well. So this is a selective estrogen receptor modulator. It's approved for prevention and treatment of post-menopausal osteoporosis, as well as for the reduction of risk of breast cancer in women with post-menopausal osteoporosis at high risk of breast cancer. It's given 60 milligrams daily. It's been shown to reduce the risk of fractures of the spine, but it does not have non-vertebral or hip fracture efficacy. Some of the side effects to be aware of are hot flashes, blood cramps, and it does increase your risk of thromboembolic events. Because of these risks in some of the elderly patients, it's not our initial choice of medication to use. And as well, it doesn't have kind of broad spectrum reduction of fracture efficacy. It just really reduces the risk of fractures at the spine. And so it's usually not our preferred agent unless a patient can't tolerate or be started on some of the other medications for any reason, or in certain populations with the high risk of breast cancer, it could be a good medication. So those are the kind of main ones I wanted to focus on in terms of what we use generally more in the primary care setting. Once a patient is started on treatment, we typically want to get a bone density every 1 to 2 years. So most insurances approve of bone densities every 2 years for monitoring. However, if you start a new medication or change the medications, then insurances will cover it at 1 year usually. So just to keep in mind, stable or increasing bone mineral density at the spine and hip indicates a satisfactory response. So even if their numbers are stable, they haven't necessarily gone up, but they haven't gone down. That's actually good. So that means the medication is working and they're okay to stay on the medication. If you do notice a significant decrease in their bone mineral density, then you want to evaluate them for non-compliance of the medications, other causes of osteoporosis, like we talked about with some of those other lab workup, or medications that might cause additional medications that might cause bone loss. And when they do have a significant decrease in their bone mineral density and they're taking it properly, and you don't really find anything else, that's when you may consider switching them to a different medication. And then I did want to just briefly talk about the anabolic agents. So these are your bone building agents. If you remember that algorithm, these ones that we consider when we are thinking about more of our very high risk patients. And these are actually daily sub-Q. There's two that are daily sub-Q injections, and there's one Evenity that has both anti-resorptive and bone building and anabolic properties. And that's given once a month sub-Q for a year. So this is, I think, in terms of the anabolic agents, if you're thinking about these agents, that's a good time that you can consider referring them to endocrine or another bone health specialist. When do you want to actually consider these? So in patients at very high risk, so if they've had recent fractures, if they've continued to have fractures while they're on other approved osteoporosis therapy, history of multiple fractures, they have very low T-scores, so anything less than -3, or they're high risk of falls, or they have a very high Fracs. Those are times that you can consider choosing these as your initial agents over the bisphosphonates or the denosumab. And that's it. Any questions?
Thank you so much, Dr. Kumar. That was really great. You provided some great resources. I see that Dr. Paliwal has unmuted. Go ahead.
Thanks, Dr. Kumar. Thanks for the presentation.
Absolutely.
I have a few questions. I mean, it's a very important topic from primary care perspective, and we struggle a lot, many of the times in different situations. Now, with the initial diagnosis of osteoporosis, you suggest that we order all those labs and check for secondary cause of osteoporosis for all patients that we find out irrespective of their age?
That's a good question. I wouldn't say you have to do it for all patients. For every patient, we always want to check a calcium, a vitamin D, a renal chem panel. I do more of the kind of intensive workup if they have very low T-scores. So definitely if they have T-scores of -3 or lower, I do a secondary workup. Or if they've had multiple fractures, if they're young and their bone density seems lower than you would think for their age, those are other kind of times I think about doing a more extensive secondary workup. Or they've been on medication, yet they're still having bone loss, then thinking about those other causes. But if it's your average patient who comes in with a T-score of closer to -2.5 and otherwise no other risk factors, you don't have to think about all of them, like the SPEP or UPEP, etc.
Okay. One of the things you mentioned that patient with osteopenia but high Fracs score, we still start them on osteoporosis medication. Do they need that secondary workup or no?
Again, I would do the basics for them. I would still do the vitamin D, the calcium, the chem panel. If their calcium is high, you would want to do a parathyroid hormone. And generally we get the thyroid labs in most patients. So that's where I would start with those patients as well.
Okay. And when you start people on medication, do you have any preference? Do you prefer that weekly oral tablet or monthly, like alendronate? Do you have any preference? Which one you prefer?
Yeah, I generally do the weekly Fosamax or alendronate is generally what I've done in the past.
And you start with like low dose 35 milligram and then go from there?
So I only use a low dose if it's a problem with their renal function, but otherwise, if they have totally normal kidney function, I do the 70.
Okay. I mean, you don't find the difference in terms of side effects or intolerance, whether you use the low dose or the high dose?
No, so I think the low dose is really only more for renal indication. Otherwise, if you're going to treat them, you want to use the high dose, the 70.
Okay. And in terms of like GI intolerance,
Mm-hmm.
okay. Now, one of the things we worry about is dysphagia.
Yeah.
Okay. So do you see more of heartburn or really dysphagia with the bisphosphonate?
I've seen more heartburn, worsening of heartburn if they have significant heartburn. In those patients, that's when I would just go to the IV form. So I would do a reclass. So if they really have significant problems with any sort of GI issues or they're on multiple, PPIs, in there, it's not well controlled, then I typically recommend the yearly reclass instead of doing the oral, because we do see an increase in the heartburn.
Okay. And for any reason, patient did not tolerate the oral alendronate.
Mm-hmm.
Okay. Like, sometimes they say non-specific symptoms. I cannot tolerate this and that. Is that an indication that they will not tolerate the reclass?
Not necessarily. It kind of depends on the symptoms. It's a little bit tricky because, if patients are having like sort of pains or aches with alendronate, I do talk to them that, if they get the reclass, there's nothing we can do. I can't stop that medication. It's a yearly medication. So I can't predict what side effects they're going to have to the reclass. If they're not tolerating it from a GI standpoint, I think they'll do totally fine with the reclass. If it's non-specific symptoms, it's really hard to know if they're gonna have those same symptoms to reclass or not.
And if they have flu-like symptoms with the reclass, okay, is there any contraindication they will not be able to take the oral bisphosphonate?
No, so the flu-like is just with the IV version. They will not get that same reaction with the PO version. And sometimes patients only get the flu-like symptoms with their first time, and they don't get it again. A lot of patients can tolerate it. They don't mind it. They take Tylenol for a day or two and they feel better, and they still get it the next year. Even if they get that flu-like reaction, it's not a contraindication to getting the IV version the next year again.
And you mentioned about that musculoskeletal pain.
Mm-hmm.
Is there any specific kind of pain or a pattern that you see which is associated with alendronate?
Yeah, that's a good question. I haven't seen any specific pattern. I think just different patients experience it different. There's not like one certain area that they say is bothering them more than the other.
Okay. And another thing is that the drug holiday, I mean, how long the holiday should be?
Yeah, that's a great question. So there's not a specific time period in the guidelines. Really, basically, after you start them on the drug holiday, you'll continue to get their bone density about every 2 years. Once you start seeing a significant decline in their bone density, that's when you want to restart treatment. So if their bone density is stable, after a couple years, you can again hold off and get their bone density 2 years later. If it's stable again, you can continue to hold off. So it's really when you start seeing the decline on the bone density that you'll restart the medication, or if something clinically unfortunately happens in between, a new fracture, et cetera, then you'll restart treatment.
Okay. And in your clinical practice, how do you really remember that drug holiday thing? Like, apart from really remembering when it was started, is there any other way you try to track it?
We just, I think it's just documentation. I think you really, in your notes, it has to be very clear what the start date was. So I generally write, the year that they started, the year that I hope to take them off if everything goes okay. And that just reminds me of, okay, now they've been on it for 5 years. If their T-scores and everything are looking okay, they haven't had any recent fractures, then I stop it. because it is, you know, some of these patients do get left on them for several years, and that's when we really start to worry about the atypical femur fractures.
Okay. And another thing is that now I heard about that in that AFP, Family Physician Journal. I cannot quote right now, but one of the things they mentioned is when screening for osteoporosis, okay, they tell that you check for one time at the age of 65, the Dexa scan. And if it's good, it's very unlikely they will progress to osteoporosis. So it's for a patient who has a normal Dexa scan at the age of 65. Okay. I mean, and even many of the time patient wants it to be checked again. Yeah. At what time will you stop checking the Dexa scan, or at what age do you stop doing the Dexa scan if it has been normal? Do you have any upper age or any?
That's a great question. I don't think we have any guidelines that say exactly when to stop checking it. I don't know, Dr. Giordano, if you have any. I can't think of what the guidelines say about that.
Yeah, I don't know of any guideline that states a stop date.
Yeah.
It's a great question.
And patients who are morbidly obese, I don't know whether in your institution you get this problem. For example, if they're morbidly obese or they have curved spine, they cannot do the Dexa scan. The technician told me. Do you see this situation in your institution?
I haven't. I know sometimes they can't do a certain site. So say like, you know, if they have issues with their spine, then we can't do the spine, but we can still do the forearm or the hip. I haven't come across a problem with them not being able to do it because of obesity. I have not experienced that.
Okay. And
I have actually, oh, I'm sorry, Dr. Paul. I was going to just add to that. I have experienced that. And what we do is just do the forearm. So in the bariatric data, they also advocate for doing the forearm because the bone density may not be as accurate in very severely obese patients. Even if you can get the hip and the spine, they do advocate for doing the forearm as a site in addition.
And another thing is, if the patient is in nursing home, okay, and we don't know when was the start date of that bisphosphonate they are on. And many of the time in the nursing home, they are either flat, I mean, they are just laying on the bed or probably sitting on the chair. They're not mobile. I mean, is there any recommendation about continuation, discontinuation, anything like that to guide, or we just keep them on it? Do you know?
Yeah, that's a good question. It's tricky because in the nursing home, they are at high risk for fall. You know, the patients in the nursing home are at high risk for falls and fractures. So you definitely want to still be aggressive in treating them. It's not something I would say that they should just forget about their bone health at that point. If it's a problem with being able to take the medication because they're flat, reclass, it's still an option if they're able to get that once a year. In terms of timing, that's all a risk. You just have to think about the risks and benefits with each patient individually in terms of if you know how long they've been on it or not. But and that's just kind of digging more, more into their medical history, medical chart. But I would still want to treat them if they haven't received a full treatment time. Now, one thing you could check, which I didn't talk about this, is a bone turnover marker called CTX. It's called CTX.
Okay.
It's a bone turnover marker, and that can help you know in general if they've been receiving the medication appropriately, compliant with the medication. That bone turnover marker, if it's low, that can indicate that they're appropriately getting the medication. If it's high, that means that they may be not getting the medication appropriately, or they haven't been on it for a long period of time. And so, and it's something that we trend over the years too. So that's one kind of lab that could help you with that question.
Okay. And I probably forgot something. I can have somebody else ask you a question. Thank you so much for
Yes,
answering me.
No worries at all. Those are really great questions, Dr. Pollywall. We always appreciate your engagement with the group, so no worries. Does anybody have comments or questions?
Can you comment on, I'm really talking very vaguely, I cannot quote. I heard about that nasal calcitonin can be used for bone pain, especially with the vertebral fracture. Can you give us some more practical advice on that? I mean, I cannot recall the details. It just I read somewhere.
Yeah, I think I don't have much more details than that, but yeah, sometimes when patients have an acute fracture and they're having pain, spinal pain, actually I've seen ortho use it too, kind of in those settings that you can use that nasal spray. It doesn't really help with the other aspects of the osteoporosis. It's more just for pain control, but I don't have, more details than that.
I definitely use it in the outpatient setting, in patients that can't tolerate bisphosphonates, in patients that don't want IV reclass or injections, or have had it and had reactions. I will say that it's different. So the nasal spray is in the hospital, but when you do the osteoporosis dose in the outpatient setting, it's harder to get. It goes through a specialty pharmacy, and it's a daily injection into the abdomen. So it's a little bit more intensive too. And it's not as common. I have had less than 5 people in my total career use calcitonin for osteoporosis. It's not ideal. It's not, your first line agents, but it can be used in people who can't tolerate, what Dr. Kumar, all the agents that Dr. Kumar listed in her lecture. It is an option. It's just not used as frequently.
Thank you.
And the last thing, in men, I mean, unless they have a risk factor for osteoporosis, now if men, they really have the age of 80 and everything, they also get that vertebral fracture here and there.
Correct. Yeah.
Okay. So, I mean, is there any reason for screening them at a particular age if they don't have any other risk factor for osteoporosis?
So, right, we screen men when they're older. I believe it's 70 or above. If they have no other risk factor, if they have risk factors like low testosterone, they're on medications for prostate cancer that might affect their bone health, some parathyroid issues, then you would screen them at a younger age. And the treatment for men is similar to females. Basically, Prolia, bisphosphonates are approved in men. There's slightly differences in approval of more of the anabolic agents in men. So that's the only difference. But otherwise, like the only other thing with the secondary workup actually in men is you would also consider testing a testosterone in them. So that's probably the additional blood tests we think about in men.
And do you do Prolia injection in your clinic, or do you do it through the rheumatologist?
It's in our clinic. They do it. Yep.
Okay. Thank you. Thank you so much.
Of course.
Thank you. All right. There aren't any other questions. Okay, ahead, Dr. Kumar.
No, that's it.
Thank you so much. Really appreciate that. The only announcement I have is the next session, Dr. Kumar is going to be discussing hypo and hyperparathyroidism, or just thyroidism.
Thyroid. Yeah, thyroid disorders. Yep.
Trying to perfect that. And that'll be on May 11th. If you have any other further questions, please reach out, and we'll reach out to her with those questions. All right. Thank you.
Thank you.
Thanks, everyone. Thanks, Dr. Kumar.
Thanks, Dr. Kumar. That was wonderful.